ladies and gentlemen, thank you for coming. And I think we're a few minutes late, but we only have 2 presentations. So we would like to start from there. So my name is Yanme Zhang. I'm an associate professor from the University of Alberta from Canada. And I'm also doing a lot of research in artificial intelligence as well as psychiatry education. So today, join me is Dr. Yuqi Wu. Yuqi Wu was a computer science and electrical engineering PhD, but did a lot of work in mental health and artificial intelligence. And he's now in China in Fudan University as a postdoc working there, and also focused on how we can use artificial intelligence to make mental health work easier and more accessible. So I will invite him to start his speech first. And yeah, it's all yours. Thanks.
Okay, thank you. All right. Good afternoon, ladies and gentlemen. My name is Yuqi Wu, and I'm currently a postdoc fellow at Fudan University. And today I'm pretty glad to be here and discuss a little bit about my research and some of my opinion regarding AI and psychiatry. So technically speaking, I'm not a medical expert like you guys do, but fortunately, I was throughout my PhD career, I was working primarily on how to use artificial intelligence solutions for to improve psychiatric problems. So I'm pretty sure everyone here in this room know at least something about AI, right? AI is literally everywhere. People use AI for writing, for reading. Even for myself, I'm using AI agent to book my tour here in Turkey. They literally help me book my hotel and plan my travel. So I think AI is pretty interesting, and there's a fun fact about AI. I heard a story that there was one time ChatGPT service was paused for an hour. The working efficiency has been reduced by 70%. So what does it mean? Everyone's using AI. So probably in the future, you guys will deal with some patients who are not alcoholic. They are probably AI addiction. Yeah, anyways, so today, lots of people are, when they are talking about AI for mental health, people primarily focusing on how do we build a AI tool for instance, diagnosis or treatment. But here we are doing it from another angle or another perspective, which is psychiatry training through simulation. So in short, today I'm going to introduce AI patient, not AI doctor. So let's get started. A little bit introduction on our team and myself. So I'm from Fudan University. I'm working with Dr. Jie Chen, who is also a pretty well-known scholar for biomedical engineering, and who was a fellow of Canadian Academy of Engineering, and he was my PhD supervisor as well. I was graduated from the University of Alberta, and luckily I had Dr. Zhang as my supervisor as well. So my research area is mainly about AI and effective computing, so which is kind of using AI or some statistical tools for diagnosing or detecting different depression disorders, stuff like that. Right, and also in general, people are using it for a broader application. For instance, right now, lots of people are using it for detecting users' emotion to distinguish between a happy user from a sad user, stuff like that. Yeah, and my research area is mainly about previously I was working on more about like AI doctors, or in specific using AI tool to facilitate diagnostic process. But right now, throughout the years, I've been more interested in like education side, because there's one pretty interesting story previously. Last year, I was in ACL, which is a top conference for AI. And at that time, I do see lots of people are using AI for mental health. And there's one point, a pretty good team, they are presenting their study for AI psychotherapy. And suddenly there's one, like a scholar, get into the stage and say, please, do not do this right now. Especially psychotherapy, where you have used like AI to interact with people. And also, like, our patients are vulnerable. So it is unethical, right now at least, to kind of like build such tool to directly interact with human or our patients. Instead, what should we do? We should start from education. We should start from better, like, how do we improve our medical education? So this is this has been my kind of like my primary focus after that. Okay, so here's a little bit background about like the AI patient, or AI standardized patient, I would say. So I'm pretty sure like everyone here knows a little bit about like standardized patient. So standardized patient is actually a trained individual who purchase a patient scenario in a standardized, repeatable way, and the gold standard for assessing clinical competence. So in psychiatry, this matters more than other subjects. For example, internal medicine, stuff like that. Because why? Because like we primarily, when we are doing like a diagnosis or treatments, we mainly talk to people. We are talking to our patients face to face. And our patients, it's really hard to find a good actor for those like mental disorders. Because besides like the physical pain we are suffering, we're more like we need the actor to act out those like mental distortions, those like cognitive like behaviors, right? This is even more difficult. That's why it's more important or more significant to find a good actor or standardized patient in psychiatry. And also, we know like OSIC examinations worldwide depends on SPs. No other method captures the dynamics, relational nature of psychiatric assessments. But human SP has like several fundamental limits. So, for instance, it's pretty expensive. I'm not sure about the price here, but like in general, like it costs like more than $200 per hour to find a good like actor or a standardized patient, and also like the cost of training is pretty high. And with AI, if we can have, imagine that like if we can have an AI who can act as standardized patient, so we can literally define any kinds of like patient we want, different backgrounds, different educational backgrounds, different like family history, different gender, different sexual orientation, different everything. You can define it. You can see lots of different models, different patients you ever seen. And so, which means you can have infinite many sessions. And also you will only have 1% of cost. The only cost you will have would be like the API tokens or like electricity fee, stuff like that. And also you can define like pretty much like any kinds of cases you want, as I said previously. So, AISP, or AI standardized patient, seems that like it's naturally a good way for psychiatric training. So people can use, for instance, AISP to practice CBT or psychodynamics or any kinds of like psychotherapy. Because right now, when we are talking about AISP, the key difference from the AISP now from before is that we are unleash the power of large language models, right? Everyone knows large language models. You can talk to it. It can interact with people. You can like ask different questions. They have different ways to answer your questions. which means we have more flexibility. We can do like a role playing with those tools, which becomes pretty interesting, right? And we can do like a clinical skill training, like OSCE examinations or crisis simulation. And also, it is like less unethical to use an AI SP than a real SP. Because especially during like those pretty severe, like suicidal ideation or like some dangerous behavior, we can easily ask AI to do that instead of like human beings. Actually, throughout years, this year in specific, there are lots of like pioneer studies in AI-SP for psychiatric education. So I only list like some of them right now, but right now we are doing a pretty like systematic review on this AI-SP for medical training. We see like throughout these 2 years, there are more than like 50 papers are correlated to how to use, like how to build AI-SP for training, for example, CBT, or suicide assessment, stuff like that. So, for instance, this study from BMC Psychiatry, they kind of like built this kind of interesting tool, and you can kind of like, it's like audio in, audio out. You can actually literally speak to your standardized patient right now. You don't have to like type in, type out. You can talk to it. And also you can define different backgrounds. You can even see the avatar. And also, like people are using like textbook-based, for example, the middle here, and they are defining different backgrounds. And as you can see, lots of people, and they do like a massive evaluations on real human beings for the feedback for those like AI patients. And it turns out like lots of people think that's a great idea, like those trainees, those like clinicians, those resident students, stuff like that. And also like there's a study from Stanford University, and they do a pretty like a pretty considerable amount of like volume, like 90 volunteer study on LLM simulated practice and feedback on upscale human counselors. And it finds that like we actually can improve the overall learning experience by using this kind of tool, because we have more flexibility. We will act like different cases. Okay, so besides education, actually this is more interesting. That like AI patient is more about training. It's more about education, and that's where my like entire research are dedicated on. It's beyond the training. Training is the millions of different ways that we use AI-SP. So what else can we do with this AI patient, I would say? So here comes to end use cases of AI-SP. So the first one is pretty interesting, sandbox. Everyone knows like the concept of simulation, right? So simulation is actually, for example, like myself, I'm from electrical engineering. So we are building like different circuits. And when we are building different circuits, before we actually hit on the board, we actually run some like computer simulation. And when I was like learning driving, I used driving like simulator. So that's the similar concept. It's pretty interesting that, because like simulator can actually simulate different scenario. So in the future, if this like AI-SP is realistic enough or have high fidelity, we can have infinite trial simulation sandbox. Here, you can literally define any types of patient, and you can propose any kind of like psychotherapy or different kinds of like, right now I think like it will take a long way to do a biological simulation, but at least for cognitive simulation in general sense, I would say like it will come like earlier than biological simulation. So actually this is not imagination. It's actually like some researchers start doing it. Like, because right now, for example, this paper from ACL, which is the top one conference for computational linguistic, which is AI area, and this paper is trying to build like a AI SP, and who can actually change or respond to a stimuli. What does it mean? So right now, imagine that if we have an AI patient, if it can change in response to any kind of external stimuli, which means we can propose a new treatment or a new psychotherapy to this AI patient, and it will change, like the cognitive model will change. So this actually become really interesting, because once we can simulate this kind of patient who can grow over time, who can stimulate in response to the environment, then we are actually building a pretty like a close simulation to what we are trying to simulating, right? So this is a pretty fun, interesting, pretty fun research I find for this type of topic. And the second way, how can we use AISP? So this is a pretty interesting area as well. So right now, as we know, like if we want to train a good large language model or AI right now, we need lots of, like millions of different data. Okay, but right now, lots of models, for example, ChatGPT claim they are run out of data, human data. So what they do, they're using synthetic data. They use like different AI to generate new data and use those new data to train or to feedback the model and improve the model. So we all know that like it is so expensive, also like in the sense of time consuming as well as a financial cost, right? It is super expensive to get enough data or clinical data in medicine area. That's why, for example, for myself, when I was first like doing my research, I was actually pretty jealous of other area, because for example, my friend who is doing computer vision, who are using like a AI tool to distinguish a cat from dog, they can easily find like millions of different pictures of cat and dog and train such a good model. But it turns out I only had like less than 100 like clinical examples to train our model. So how can we solve that? We need, because like naturally to train a good AI model, we need enough data. Otherwise, we'll easily overfit and get like a pretty bad result. So at that time, I was thinking that like, what if we can use the concept of role playing? At least like if I ask enough clinical questions and we define like our AI patient story well, then probably we can get a pretty authentic and usable data that we can train our model to get better performance. That's our process. This is actually like a research we done like 3 years ago, and where we starting from like a data set which only had like 200 data samples. And we defined like lots of different like patient backgrounds, and we use AI to conduct like role playing to generate synthetic data. And our experiments shows that after training with our data, actually it boosts the performance by 30%, like the original model. And also we use like human evaluations as well, and it turns out our data is really, really authentic. We cannot say that it's close enough to the clinical point, but let's think about this. Why do we need to train an AI model, or what kind of information that the AI model need? It's how we distinguish from, for example, a depressive patient from a healthy patient, right? So we only need those kind of clue, And how can we get those kind of clue? We can kind of like generating those different cases, and then we can expand our data set, and we can get a better model. That was our research previously. And as I said, like by utilizing our method to kind of like getting more data, we starting from 163 data points, which was the original data set, we expanded to almost 2,000. And we resolved the overfitting issue of the original data set. And also we get like at least 20% of like improvement on the diagnostic performance. Okay, the third use case is the benchmarking. So what's benchmarking? Is whenever like we are testing, for example, how do we know ChatGPT is better than Gemini or Claude or any kind of different AI? It's through benchmarking. Benchmarking is kind of like a target. Or for instance, if we are testing the mathematics solving capability of a large language model or an AI, what we do is run through, for example, 1,000 different math questions. And after we run through 1,000 different math questions, and then we get the percentage of correct, right? If this is like 70% or the other is 80%, then we know the other one, which is 80% one, is definitely better at like a math problem solving, right? So if we have like a pretty good like AI patient, we can become such benchmark for lots of people. I'm pretty sure lots of people are doing like AI psychiatrist or AI doctor nowadays. And this can be a pretty good benchmark for those like different AI tool who claim to be a better medical problem solving. Actually, people are doing this as well. For example, this CBT bench, which use like they define like I remember it's like several hundred different cases, CBT cases, and ask the current like the trending AI models such as like a GPT or Claude to solve those questions and see which one is better at like CBT problem, right? Okay, another one. It's actually it's not getting there yet, but we do see the trend. We know like when we are doing like clinical trials, previously we have what we call like in vivo and in vitro, right? So we can do it with animals, we can do it with like lab material, like living organisms. And right now, imagine in the future, we can do this with our simulation. Because why? Because we define lots of different AI patients and with different backgrounds. So in the future, like if this is pretty good, it's good enough or authentic enough, then probably we don't need like recruit 200 patients or 200 volunteers. Instead, we can define, for example, 10,000 different AI patients instead, right? And we can probably have more robust or like more general results from our in silico clinical trial. And it's worth trying because it takes literally nothing. We don't need to spend like 1 year or 10,000 US dollars to kind of recruit 200 people and to verify if our model is working or not, right? Because we can easily, for example, spend a week at least to generate like 10,000 different patients. And even though, like, here comes to the concept of simulation. We are not saying simulation have to be exactly the same as real human beings. But what's good about simulation? It helps you see the trend. What we need or what can speed up the process is the trend. If it goes up, then we only need the information that it will go up, not like go up by 20% or 30%, right? That's the point about simulation. Yeah. So in our recent study from MBCA Digital Medicine, we actually come up with a pretty interesting way to kind of like test if our AI diagnostic model is good enough for differential diagnosis. So in this study, because previously we are, if we design such like chatbot or diagnostic model, we usually use patients, like real users or patients to determine if this is working or not. But right now, in this study, we are using AI standardized patient to do that. Because why? Because if we define like different patients with different background, at least we can test if it can diagnose correctly or not. That's kind of like in that study, we actually split the evaluation process into 3 different dimensions. One is specifically for what we call diagnostic or medical reasoning, where we use like simulated patients to interact with AI and to see if AI can get it correct or not. And in the second level, we use like, we are targeting different perspective because we are building a system or a chatbot, right? So we are interested about like if the patient or if the user is comfortable with our system. So that's our second dimension, which is user experience. And the third dimension is because we are building like a medical professional tool. So we ask a group of like medical professionals to kind of see if this is professional or this is precise or not. And also, this is another interesting research that we are doing right now is AI doctor versus AI patient. So this is actually pretty interesting because I'm not sure like anyone here knows like the concept of gain or it's kind of like a adversarial network. So general adversarial network. So we don't need to know the concept behind it, but we just need to borrow one concept, which I think is pretty beautiful. So originally, gain. Why do we use gain? So gain is for picture generation. We want to use AI to generate picture. So how do they train those models? So in this network, they have 2 parties. Thinking about during a war, we have 2 different parties. And the first party is what we call generator. The objective of generator is to generate authentic or realistic picture that is so realistic which will fool the discriminator. So on the other side, what's the objective of discriminator? Obviously, we want to distinguish, no matter what kind of picture you generate, I want to tell if this is real or false or fake, right? So you see, throughout the network, you have 2 opposite different objectives, and they are improving each other in one iteration. So can we borrow the same concept when we are training, if we have like a good AI diagnostic system or AI doctor, I would say, and AI patient? Then how about, because they obviously have different objectives. One is to making itself is more like realistic, and the other is trying to diagnose, making like a good diagnostic performance, right? So that's kind of like our concept of adversarial optimization. Yeah, this is actually this idea is borrowed from I'm not sure if people know like DeepMind and AlphaGo, right? There is a pretty interesting algorithm called self-play. So with self-play, you play with yourself. So it's kind of like the point, like myself is playing with the previous myself. So it's kind of like what we call reinforcement learning. So in this system, I'm continuously playing with different versions of myself. And then eventually we will converge to a best myself. So that's kind of self-playing. That's what we do, what we can do with AI patients as well. It's actually happening, and there's several studies in Nature, which conducted by Google. Actually, they are using this kind of self-playing algorithm to improve diagnostic performance. For instance, the animation on the right, you can see throughout iteration, they have patient simulators, and they have an external critic, and they will the external critic will see, well, this is correct or this is not correct, and by those rewards, what we call, and we can use this kind of as a reference to improve the diagnostic result, and eventually get better and better model. You see here, we are actually not introducing any external data to retrain our model. That's different. That's kind of we are using our inner capability to improve ourselves. It's kind of the way how human beings are doing learning, right? We using others' feedback and change the way we are performing different tasks. So this is pretty interesting. And that's about the AI patients or AI standardized patient. There is actually a pretty interesting concept. Is when a couple of weeks ago when I was discussing with Dr. John, and we are discussing should we call it an AI standardized patient or AI patient in general. Actually, it turns out we think that it's both way. It's by different perspective or different contribuability. For instance, if we are using AI to build a patient, it's not standardized patient, then we will have obviously more flexibility and less controllability. And the other way is if it is more controlled, then it's what we call AI-SP or AI standardized patient. Actually different from the previous introduction or different use cases. We can see different use case require different flexibility or controllability of this AI tool. And right now, this is actually a pretty new field that barely people or researchers are working on. That's why I'm here to kind of introduce this concept and probably invite everyone to kind of start working on this kind of interesting field. Because right now, I would say in general, we are at a pretty normal or fair fidelity level, which is only using a pretty simple prompt engineering or prompt to kind of do a role playing. What we need actually, how can we build? So from the previous cases, all assumptions are based on that we have a pretty good AI patient. How can we build an AI patient, at least a usable AI patient? Personally, I think there are three open challenges that we need to resolve right now. The first is cognitive model simulation. So right now, we are classifying the current study by what we call language-driven and strategy-driven. So what is language-driven? Imagine you are using ChatGPT and you say, oh, now you are 25 years old, for example, Chinese male, and you have such different educational background, whatever, and you feed this to the prompt. And you ask GPT to act as the patient. This is role-playing, this is language-driven, because you use prompt-driven, this kind of formulation. The other one, I would personally, I think is better and making more sense is strategy-driven. For example, CBT, right? There's a pretty interesting study. It's called Patient Psy, where they use a CBT model to build AI patient. For example, we starting from the core belief. Instead of all stories, they actually use cognitive model from Back Institute, like what's the core belief, what's the intermediate thought, what's the coping strategy, and what would be the automatic thought. So as you can see, they are defining the whole cognitive model of such patient instead of just using like a prompt as a background information. And this comes to a more interesting and more unexpected result, which this is, I think, will be more interesting future research area. And also the dynamic evolution, which is if we have external stimuli, can it change its cognitive model? So the first one and the second one, the first one is static. The second one is dynamic. How can we transit from the first cognitive modal state to the second cognitive modal state? So that's the dynamic evolution mechanism that we need to figure out, or at least simulate. And the third is multimodal clinical expression. So lots of people, if you are working with AI, probably you heard like multimodal diagnostic or classification for depression. What's multimodal? Is instead of just like your language, your content, if I said I'm like, I lose my sleep or lose my appetite, and you also have your vocal or acoustic feature and all your facial feature, that's called multimodal. And people use multimodal to determine this person has or has not like depression. And right now we are thinking about another way, or an opposite way, which is multimodal representation or generation. Because we don't need, or we don't always working with an AI patient that we only use our keyboard to communicate. We want more authentic or more emergent or more like immersive way to interact with our AI patient. That's why we need like a multimodal clinical expression. So what this means for clinicians and educators. So for clinicians, I think like personally, I think AI diagnostic tools you will use will become more reliable because they were tested against the realistic adversarial patients, not just like textbook cases. And your clinical expertise is the most valuable input, and your feedback will calibrate how this AI patient behave. And future clinical trial may use virtual patients cohort to pretest protocols before you enroll real patients. Actually, think about this. You can actually speed up your validation process, right? Especially when you are using AI tool, developing AI tool. And future, and you are not being replaced because like you are actually empowered with better training tool and safer AI systems, because this is literally a training tool, or it's a tool for a better use of your time and getting like a better educational levels. And for educators, this is pretty obvious. If we have like an AISP or AI system, we will in the future, like your patients can practice like real disease, real psychiatric cases 24/7. You can literally generate any case you want, any kind of case. And we can use it for exams, and you can create crisis scenarios and which are too risky for human actors, for example, suicide, stuff like that. And you can observe and replace student interactions for feedback, and sometimes impossible for live standardized patients. And yeah, I think, so in the future, if you are interested in this kind of a research, because that's kind of like one of our signature research that we are continuously working on. So if anyone who is interested in it, don't feel hesitate to reach out to me, and we can build this together and making this like more interesting. And here are some of my contact information. And yeah, that's it. Do you guys have any questions?
Thank you, Dr. Wu. Okay. Now I'm going to open the floor. Any questions to Dr. Wu? Yes, Dr. Greenshaw.
Do you have a mic?
Do you have a mic?
Thanks.
Okay, thanks.
Thank you. Well, thank you very much for a very good talk. It was very clear. And I like that you were asking people whether they understood AI concepts. I think people have a familiarity. In figuring out whether this is safe and usable, one of the big principles that we are all repeating all the time is that you need a human in the loop.
Yeah.
Do you think we will get to a stage where we do not need a human in the loop? Or do you think this is an inviolable principle that you just will always have to have a human in the system?
Okay, yeah, that's a good question. People always think always say if we need a human in the loop. I would say the answer is I think humans should always be in the loop. Is the matter of at what point, at what a stage that people get involved or into the decision-making process. I would say for instance the autonomous driving right now, right? Because AI cannot take responsibilities. After all, human beings should will take the responsibility, who get the final signature. So it's kind of you're asking different interns to do all the work, but you are the supervisor. And at the end of the day, if you are getting into any trouble or any big events happening, then you will be the responsible person because you give the authority to the interns. So I would say yes, I think humans should always be in the loop. Yeah. Thank you.
Thank you. Any other questions? No? Okay. Thank you very much. Thank you, Dr. Wu.
Thank you.